Good morning, all. Happy Friday. My name is Ann Hill, and I am the Associate Chair for the Culture of Data Conference. Along with my chair, Taylor Bostick, we are really excited to see you here today, which is day 2 of the Culture of Data Conference. Before we begin, I want to just push out a huge shout out to the Culture of Data staff, Rachel, as well as Ashley, for making this whole virtual conference possible. But also I want to shout out to our Culture of Data committee members too. These are volunteers that help us run this virtual conference. We're really thrilled to start today off with something completely and totally new. This is the first time that we've ever tried lightning talks for the Culture of Data conference. And the intention behind these talks is to have speakers highlight emerging or cutting edge trends, including AI-driven health solutions, emerging technologies, future public health workforce activities, youth engagement, and next generation data strategies, all with the intention to dismantle systemic inequities. These lightning talks intersect with our Culture of Data theme, which is data science for health justice, addressing the social determinants of health, and specifically presenting on how data science is reshaping access to care, housing, employment, and environmental conditions. I now have the pleasure of introducing our lightning session sponsor. Again, we would not be able to deliver any of this wonderful programming without the support of these amazing organizations. I would like to introduce Kylie Yoakum from CDPH&E's Prevention Services Department to say a few words. Kylie, are you here?
Yeah, hi, good morning. My first time talking today, so I think I did pretty good of my morning sounds. Anyway, my name's Kylie Yoakum. I use she, her pronouns. I am thrilled to be here today representing CDPHE and PSD. I am the drug epidemiologist in our prevention services division. I get to work with our overdose prevention staff on substance use and mental health epidemiology, which is a cause that I'm sure is near and dear to many of us here. As I said, I'm excited to get to represent CDPHE and the Prevention Services Division. CDPHE's mission is to advance Colorado's health and protect the places where we live, learn, work, and play. At the Prevention Services Division, we strive toward this mission by working to improve the health, well-being, and equity of all Coloradans through health promotion, prevention, and ensuring access to healthcare. So we've spent the last day learning about innovative methods that our colleagues in Colorado have used to promote health justice and how our data systems and methods can be leveraged to promote health for Coloradans and uplift marginalized communities here in Colorado. Now we get to look to the future, to how emerging strategies and data systems and applications can innovate our field and promote health justice in times that bring funding challenges and uncertainty every single day. It is more important now than ever to lean on our colleagues and our collective wisdom to carry this work forward. I've put together some guiding questions to move us forward in this session. They are, how can we balance the innovative power of new technologies while ingraining health justice and equity principles into each stage of this process? How can we work to improve the sustainability of our field for the future leaders of tomorrow? And that's enough for me. We have some incredible presentations lined up and incredible content. So without further ado, I'll pass the mic back over to CPHA.
Thank you very much, Kylie, and to the CDPH&E Prevention Services Department. I'm going to keep those questions that you just posed in my back pocket in case we are able to, sort of pepper these throughout the presentations. We really appreciate CDPH&E and all our sponsors for their support in bringing this conference to life. I will now pass it on to Kalinda Gupta, our moderator, to give us a brief outline of the session and to get us started. Kalinda.
Thank you, Anne. Welcome to the lightning talks of the 2025 Culture of Data Conference. Thank you all for joining us this morning. I am Kalinda Gupta, she, her, hers pronouns, and I will be moderating the session as Anne mentioned. We also have Rachel Massman, she, her pronouns as well, who is managing the Zoom and making sure that all the tech is running smoothly. You're all muted now, but if you have any questions during the Q&A sessions, please feel free to unmute then. We will hold all questions until the very end. You can also use the chat box if you have any questions throughout the presentations or need anything else. If you're comfortable doing so, please add your pronouns to your Zoom name by clicking the 3 dots on your video square now and select rename. It is now my honor to bring you our lightning talks. Each presenter will present approximately 5 to 7 minutes consecutively. We will ask that you write down your questions and hold them until the end of the presentation. We will leave about 15 minutes for the Q&A at the very end of the presentations. You will hear from us once again more before we break out into our sessions. But at this time, we will turn the platform over to our speakers, so please enjoy, stay engaged, and welcome.
Hello, everybody. Can you hear me? Wonderful. Pleasure to meet you all. I'm going to go ahead and kick it off for our fantastic speakers today, hopefully myself included. I am Dr. Stephen Moyo, CEO and founder of Wealthy. I'm a physician. I practice as a hospitalist, and I've been doing so for over 20 years in hospitals. And the honest truth is I've never seen it as bad as I've seen it right now. In the past year, we've been seeing an influx of youth into our emergency departments, and I want to tell you about one of those cases. Maria is a 16-year-old girl, and she came into my emergency department after taking 60 pills in an attempt to end her life. Maria was sad because after a recent move, she felt alone and disconnected from family and friends, and she was angry, not because she tried to take her life, but because she did not take enough pills to succeed. In the past year, over 500,000 youth have been showing up to pediatric emergency departments in a mental health crisis. And a big part of what is driving this is a lack of community-based mental health providers. In the US today, we are short over 300,000. And I know a lot of you in Colorado, right in Denver, and perhaps down the street from you is Coors Field. And I want to take a second to put this number into perspective. 300,000 mental health providers, that's our shortage. That is equivalent to 6 Coors Fields of providers that we need to be able to meet the demand for mental health services in our community. And in Colorado alone, it's estimated that by 2030, there'll be a 30% increase in demand for mental health care workers. And in 2021, there was a study done in Colorado that showed that 40% of high schoolers were having mental health symptoms. So it's safe to say that the supply is not matching the demand. And it's why we at Wealthy are really focusing on building and empowering this youth health workforce that we call the youth force. The youth force are young people, usually ages 18 to 24, but they can get credentialed to become either a community health worker, peer support specialist, or an early in career behavioral health provider. And they can do this actually via apprenticeships as well as working through community colleges. The youth force is unique because what we do and focus on is recruiting these youth starting in high schools. And so what you see here on our screen is the progression in our vision from certificates in high schools through apprenticeship and credentialing locally through apprenticeship programs and in partnership with community colleges, and ultimately getting these individuals credentialed and into their career, where they can bill Medicaid for providing essential services like health education, care coordination for youth like Maria, right in schools, camps, and community settings. Our goal at Wealthy is to do this uniquely, leveraging modern technologies. So if you could skip to the next slide, please. Thank you so much. Right now, at Wealthy, we're happy to announce that we actually have launched our virtual patients. These are unique because they are specifically for pediatric mental health. We're building with this in mind. And the idea is to really focus on the most common issues that not only students and youth are facing themselves so they can better develop their capacity to help their friends, but also work on professional development for school leaders such as teachers and school health staff, counselors, social workers, and psychologists. And last but not least, in high schools, use this to enhance career technical education. So youth can start to get an experience of what it's like to care for virtual patients. And we've already validated that this is going to be valuable not only for career technical education in high school, but for apprenticeship programs and exam preparation, but also for continuing education for health professionals that are in the field. And what is unique about our virtual patients, if you could skip to the next slide, please, is that we are actually building out with these three core competencies of intelligence. One is we actually co-develop these virtual patients with youth. They are sharing their personal stories, stories of their friends, actually writing these down, and these stories become the backbone of these virtual patients. This is not clinicians like myself trying to imagine what it's like to be a kid today. It's actually youth who are going through it, sharing their stories. So these are authentic stories, and we're able to capture what is happening for youth today. We also are layering on the clinical intelligence. Our VP of behavioral health is a clinical psychologist. We're bringing in pediatricians, parents, as well as youth into this as well to really understand the clinical dynamics that our future health force needs to know. And the last piece is cultural intelligence. We're building this with communities, particularly the communities that are hit hardest by mental health issues. Hispanic communities, Black communities, BIPOC, LGBTQIA are all part of this key puzzle. And our goal is to really build the biggest library of pediatric mental health patients, virtual patients for the workforce to be able to not only practice, but really learn the key skills that they need to deliver services. If you could go to the next slide, please. So we think these employees are going to be really important for the public health workforce writ large. So whether they're working in hospitals, clinics, or ideally where we would like to see them in schools, camps, and more community settings, this is going to be essential as we get the future workforce trained up, not only with virtual patients, but also AI tools for the future of healthcare. And so our vision is to build the Colorado Youth Force working through high schools, community colleges, and in partnership with local employers to make sure that the future workforce not only knows how to use AI tools, but has been trained with AI virtual patients to bring compassion, empathy, and cultural relevance and competence to their work. Thank you.
Good morning, everybody. Rachel, Kalinda, can I go ahead or
Yep,
do you want
absolutely.
Okay, thank you. Hi, everybody. This is Garvita Thareja, faculty at MSU Denver, and my topic is about AI in healthcare delivery, and we did a systematic review. Next slide, please. So for this presentation, I have a little bit of roadmap where we'll do an ice-breaking activity. And then we'll go over the study details with purpose, methods, results. And then in the end, we'll go over some of the discussions where I want to know more about your thoughts with the findings and what can be done, just like Kylie mentioned about sustainability, some of those areas. So we have close to 96 or 100 people, I would say. So for the ice-breaking activity, I just want you all to put something exciting that you are doing this weekend in the chat, because if I will have you all unmute, then we'll just use up the presentation time. And I'll start with me as an example. So for this weekend, I'm planning to go to Hot Springs, which I have not done that before. So I'm excited and looking forward to it. So if you can please put one thing. Yeah, thank you. I see the chats coming in. So the purpose of this activity was to look into the use of AI, because AI is now gaining so much popularity in healthcare, and how it is being used in the healthcare delivery piece as well as in public health. So there were mixed results in the literature, where some of the authors in the peer-reviewed article said that the AI is being used and being successful in the healthcare delivery, while some of the researchers were a little iffy on it because of the training cost and implementation that goes into putting AI in launching in healthcare field. Next slide, please. So for methods, we looked up at last 5 years of data, and we looked at the scientific databases, and we have inclusion criteria with the search terms. We used the search terms related to AI in healthcare practice or imaging, diagnostics, med schools, labs. So a mixture of these terms we used to find the peer-reviewed published data specifically on AI delivery in healthcare field and public health. Next slide, please. So our initial research yielded 638 articles. And then after removing duplicates and some of the articles that were not in English, we came down to 541. And then we further reviewed abstracts and titles to see if they fit the healthcare delivery field or if they were something else, because online would just pull up anything when you put in AI. So from 541, we came down to 209 articles. And then further, we read the introductions and some of the methods that they used. And then we had, in the end, 25 articles that were used in this analysis. Next slide, please. So the studies reported that AI is being used in healthcare delivery, and the number did went up post-COVID because of the virtual and telehealth that we are using. So we are also using AI in those capacities. And then mostly it's being used in imaging and diagnostics with the labs, especially for like cancer treatments and early detection of skin cancers and for women breast cancers. Some of the minimal invasive techniques are now also using AI so that the patients can have better health outcome and quick recovery and less hospital stay. However, some of the concerns in those studies were about the lack of training among the healthcare providers, because the system is already burdened, and then the healthcare providers to patients ratio is already not in a good shape. So these healthcare providers are not being offered as of now any CE credits where they want to engage their time in getting trained to get to learn the machine and understand the machine learning in AI. Some of them do offer, but broadly it's not being offered. So that's some of the barriers that some of the authors reported in the AI. And then the cost in implementing the new machines and new technology versus what they have been using for so much longer period is another barrier. In public health, especially in academia, like for example, med school or pre-healthcare areas, there's very limited use of AI and AI-based projects and curriculum-wise. So that was another barrier that we have. Next slide, please. So here I want to spend maybe, I don't know, we have maybe 2 or 3 minutes, but some minutes about your thoughts, if you can unmute yourself and share your thoughts about AI, and if you have experienced one with your healthcare journey, and then how do you think AI can really help or not maybe in human touch in healthcare delivery or public health? And then going back to Kylie's question about sustainability, I was just wondering that how can we become more sustainable if we use AI in healthcare delivery? Like, will it be sustainable, or is it just something we are doing at the heat of the moment with technology and the wordings and yeah. So any thoughts? The floor is open. And then I do see some chats going on that I kind of agree, Sunena, that it will not replace humans, but then depending on how it's used, probably it'll maybe give them more power, more backup, and like making the healthcare delivery at a better rate with the barriers that we have right now. But I see most of Kalinda saying sustainability, yes, but needs to be taught appropriately, because when we were reviewing the articles, there were not many med schools and healthcare schools, like pre-healthcare, that were using or even discussing about AI into practice and how it'll look like. So if we are looking at implementing AI at the healthcare delivery field in the future, I think it really starts from the school level education, where we are not just using ChatGPT for doing assignments, but really understanding the role of AI and how can these machine learning and coding can help in healthcare delivery. And I see some charts going on, but I think, and Kalinda, that's the last slide I have. Thank you very much for listening my topic. And if you have any questions, that's my email. Thank you.
All right, we'll introduce our next presenter.
Hi, everyone. Welcome to our session, Engaging Youth to Reshape Health, the Power of Youth Councils. My name is Chanel, and I'm a youth advisor at the Community Action Team, and I'm also a third-year CU Denver undergrad student. I'm excited to be co-presenting today alongside Stacy. We're here to talk about the Youth Council on Mental Health, which stands for YCMH. We are a youth-led, adult-supported initiative dedicated to improving mental health outcomes for young people across Colorado. The YCMH is made of 3 teams: the Community Action Team, the Program Innovation Team, the Patient Experience Team. The council is also supported by Partners for Children's Mental Health, which is a department in Children's Hospital. PCMH plays a key role in training adults to recognize and prevent and respond to mental health challenges and to help connect youth with the support they need.
Hello, everyone. My name is Stacey Adimu. I am also a youth advisor alongside Chanel, and I am a senior at University of Denver. Next slide, please. This slide captures the core of how YCMH views youth engagement. When we say nothing about us without us, we're talking about moving beyond youth being talked about in public health spaces to being active decision makers in them. Youth councils like YCMH help to bridge the gap between young people and the adults shaping public health policies, programs, and systems. We don't just listen to youth, we actively share power with them. That looks like creating spaces for open dialogue between youth and adults, using youth insights to actually shape policies, training content, and program design. When it comes to youth engagement, we hope that you regularly ask yourself, are you truly sharing power with youth, or are you just checking off a box for youth engagement? At YCMH, we aim for the top rungs of Hart's Ladder, which is a framework to lay out the levels of youth engagement where youth lead, co-create, and challenge systems. Next slide, please. So this is how YCMH is structured. It's a creative, intentional, and rooted in collaboration. We're made up of 26 youth across Colorado, and we're all working towards the same shared goal, which is shaping a better, more youth-centered future for mental health. But instead of doing that work all in one group, we've split into 3 different focus teams, each with its own lens. Each team consists of 3 youth on leadership team, 1 adult supporter, and up to 10 youth council members. The Community Action Team leads youth-driven initiatives out in Colorado communities. They focus on things like awareness campaigns, stigma reduction, and uplifting student wellness. The Program Innovation Team works on giving input on internal research, trainings, and advocacy projects to make sure youth voice is driving change from inside and out. And the Patient Experience Team collaboratively works with Children's Hospital Colorado, working to improve what it feels like to seek and receive mental health care as a young person. This setup allows for us to reach different systems, from schools to clinics to research programs, while all staying connected under one shared mission. Next slide, please. These are some of the key strategies we found that work well when it comes to building youth councils that are meaningful, inclusive, and impactful. First, all of our work starts with community. We have to foster a space where youth feel safe to be themselves, speak up without fear, and lead. That might be with starting a meeting with a grounding question, like mindfulness or a lighthearted question. Things that let people bring their guard down and also bring their voices into the space. Next, it's important to know who is in the room and who is not in the room. Every youth brings their own lived experiences, but they shouldn't be expected to speak for all youth. We are intentional to make sure that every voice has a place. We also talk a lot about balance, especially when it comes to decision making. Not every youth needs to be involved in every decision, but everyone should feel informed and included. Knowing when to keep a discussion going and when to move forward is part of that leadership skill building. And finally, we are intentional about recruitment and retention. We bring in youth who may have never done this type of work before, and most importantly, we pay the youth. It's not just about fairness, it's a way to show them that their time and insight matter, just as it would for any other adult partner. Next slide, please.
Now we want to touch on some key areas where youth engagement really makes a difference, specifically its impact on research, on youth, and on adults. So starting with research, when youth are involved in public health research, the work becomes more connected with real life experiences. Their input helps shape how data is collected and what's actually being measured, which leads to findings that are more accurate, relevant, and inclusive, especially for diverse communities. In short, youth engagement helps public health research become more impactful and meaningful. Now, the impact on youth. Being a part of this kind of work gives young people a chance to participate in real-world public health efforts. It's a place where they can apply their skills that they've learned and actually see a difference in the world that they're making. Mentorship plays a big role here, where youth gain guidance and exposure to different career paths, which builds their confidence and can helps them imagine a future beyond just public health. And when public health is connected with social justice, it helps youth understand systemic issues and empowers them to advocate for change in their own communities. And finally, the impact on adults. When we center youth voices, Adults gain valuable insight into what young people are experiencing. This helps create public health strategies that are more responsive and relevant, but it also brings attention to the importance of transparency and ethical responsibility, which makes sure that the efforts are shaped by the needs of the communities that people serve. And lastly, again, mentorship becomes more than just guidance. It's a space for mutual growth, shared learning, and making real and meaningful connections. Next slide, please. Lastly, we want to leave you with some key takeaways from today's session. So youth do deserve a seat at the table. Decisions that affect them should be there. They are also shaped by their voices, their lived experiences, and their leadership. Engaging youth, especially those from underrepresented backgrounds, help build a more inclusive and diverse public health force and truly affects the communities that they serve. And when youth are involved in meaningful ways, public health efforts become more responsive, timely, and relevant to the community needs. The result of this, the outcomes are not only effective, but they're also more equitable. Next slide, please. Thank you all so much for your time today. If you have any questions, please feel free to reach out to the info@pcmh.org. And if you'd like to learn anything about the Youth Council work or services offered by PCMH, we'd love to connect with you, and our information is here. Thank you all.
Thank you. I'd like to invite Nicole Carlson.
Hi, I'm Nicole Carlson. I'm here from the Colorado School of Public Health. I'm currently the interim chair of biostatistics and informatics. In my real job, I run our collaborative biostatistics and data science center on the Anschutz Medical Campus. So I have tons of comments about one of their earlier questions. But I'm going to tell you about what we're doing in the school. And so I'll go to the next slide. So our dean recently gave a talk on CPR, commenting on how 40% of the public health workforce left the field during and after COVID. And so we have this huge responsibility as a school to help educate and bring back our workforce at a time when we're also having huge scrutiny in public health initiatives at our very highest level of government. Next slide. So, and then near and dear to my own heart, because I'm a lover of data, data, more data, it's everywhere. It's where all of these sessions today are highlighting how there's data in everything that we do now. And it means that we need every single student who leaves the school to be data savvy and think about the implications of how they're using data. Next slide. So what are we doing? And so this is a quick slide. Next slide. So we're increasing our number of offers and admissions to the school. So if you have someone that's interested in public health, we will help make the case on why it's still an important discipline to be in. And I'm so inspired already just listening to the few talks of that almost everything you do, if you have a public health degree, impacts humans and people in meaningful ways. We have worked really hard over the last decade, because we're a new school, to limit our tuition increases, and our tuition is below the median nationally for schools of public health and in public schools too. And then we've greatly increased our student scholarship dollars. We're working very hard with the current climate on how we can continue to keep growing a very diverse student population and comply with federal regulations. And so I want to be clear that everything that they offer is available to everybody, but it still has a focus on that we want to educate. As we're hearing here, we want voices from everyone, because the impact of public health, we need to have those voices in our school. Next slide. And so we've modernized our curriculum. And as everyone was saying here, we need people I think about us as modeling data. And so on the AI side, on the bottom, I have a ton of classes that are being offered in the School of Public Health in my department of biostatistics and informatics. But at the top, we also have communication skills. This will become critical as data become more complex. How we talk about it is very important. And we also look at the informatics side at the top. And a lot of these classes are accessible to everybody. I went through our whole course guide. And then I'd say hot off the presses is there's faculty who are trying to develop some summer institutes on AI that I think about as how AI is in practice. Next slide. And so I'm going to talk a little bit about what I know near and dear and what the Center for Innovative Design and Analysis is doing. They've done undergraduate pipeline programs to give students positions over the summer and during their year to work with data. We have an internship specific for applied MPH biostat students because they often don't get hands-on experience. And then we have a summer institute funded by National Institutes of Health, which they say is still continuing. And so we fund two practical hands-on programs for co-sub students. And then in biostats in particular, 83% of our MS and PhD students are funded. And so they're getting to actually touch data. And then the center offers 6-week data literacy courses. They're all remote now. And so if there's a forum I can give out, anyone can sign up for them. There is a cost for the instructional cost, but they're really about advancing data literacy all the way from study design. And this year I was talking about bringing on an AI course. Next slide. And so I highlight here 2 things. This is from the Centers for Health, Work, and Environment. They're funding a student and they gave them a mini grant to do evaluation of environmental exposures for people who work in food trucks. And so there'll be tons of complex data that come out of this. And so they're getting a very real world experience. Next slide. This is one of my own faculty who is going now for their PhD, and we worked with someone in Alzheimer's and how they can do remote assessments and showing that remote assessments for cognition actually perform just as well as in person, which would really help us not only we were bridging the digital divide by giving how to get iPads out in the community so they can do these digital assessments, but also then expanding healthcare in an area that has great demand, as we've heard earlier. Next slide. And so we also then don't just want to educate this next generation, we want them to have jobs. And so all of our alumni know that our students are strong and they hire our students at their companies. And they know that they're very practically oriented. And I looked up the data and 99% of our students are getting employed after graduation. And so I'm proud to say that our school is really not only just trying to solve this problem of getting people educated, but also making sure that it's a meaningful degree because you get work after. I think it's my last slide is next. And so this is a picture of one of our summer institutes. I just love to see the bright smiling faces. And they are really, even if public health jobs right now retract under our current administration, which makes me want to cry, I want everyone to remember that everyone in public health comes out with amazing skills. They're talented, they're curious, they wrangle data, they code and just do all this amazing data digging in a way that just was not there 30 years ago when I started. And they are, every single one of our students when I work with them are change makers. And I just think that hungry is such a great skill in jobs. So I'll end there.
Okay, good morning, everyone. Happy Friday. I am Nick Behrens. I lead our health and human services work for the AI and data practice at IBM Consulting. This is my first lightning round. Love the concept, and I'll try not to sound like an auctioneer while I'm up here. Okay, so in our talk, have an idea to share. How about less paperwork, more public health? I think that's an idea we can probably all support. Where to start? Let's start with the belief that, we're here to solve real world challenges that impact people, like Dr. Carlson just said. It's about the people at the end of the day, their health, their safety, their well-being. Take Colorado's wildly important goals, an idea that I absolutely love and find incredibly inspiring. These are deeply personal, ambitious goals. And when public health is working well, we get to shape futures, we create opportunity, we're building stronger community. But that takes time. It takes presence of mind. And when we're overloaded with the wrong kinds of work, too much of the filling out forms, the digging through spreadsheets, the lookups in this system or that system, it takes us away from what really matters. So the opportunity in front of us, North Star here, is help public health professionals spend more time doing the work that really matters, helping people, supporting families, improving communities. How do we get there? Well, we believe that we need to rethink the experience of work, let technology and AI do those parts of the work that take us away from helping people, from the work that really matters. Next slide. I want to take just a quick minute to talk about the tech here. I'm going to introduce you to two different ways of using AI, both helpful depending on what you need. We're all familiar with assistants, Siri's, Alexa, Google Assistant. They're great at simple tasks. I ask it to set a timer, sets the timer, lets me know when the time is up. Somehow I still burn dinner, but it does its job at least, right? And you can ask it even for a forecast, or maybe even ask a trivia question. It's good at these simple tasks. Agentic AI, on the other hand, is designed for more complex, multi-step work where we have different actions that need to happen across systems or content, even areas of expertise. They're more like digital teammates. They can collaborate with people and other agents. They can learn, get better, just like some of us, right? And handle workflows end to end. They can take on personas even that focus on, let's say, public health priorities like research or policy or education. Using agentic AI is how we give more time and support to our teams to really use their expertise, the human parts of the work, as I would call it. Next slide. So I have a real world example. Always a fan of an example just to help bring it to life. Short story from another part of our work in health, the pharmaceutical industry, one of the most complex, heavily regulated industries in the world. As many of you might expect, bringing new pharmaceuticals to market requires an enormous amount of documentation, much of it manually authored under tight timelines, governed by really strict compliance standards. It consumes lots of time for highly skilled people doing that manual work, regulatory writers, quality reviewers, clinical specialists, legal teams. And I'm sure, many of us can relate in our own experiences to this kind of having to do all this manual work, right? So with agentic AI and the right safeguards, bold underscore, there are ways to speed this work up without sacrificing quality or trust. And AI agents can work together to gather the data for us. For example, from approved sources, they can draft sections of content that align to the submission templates. They can cross-check factual claims against data source documents for us. They can format content to make sure that it complies with regulation. They can even structure everything according to agency guidelines. Really important. We always keep a human in the loop in these situations, guiding, reviewing, making final decisions at key points in the process. The more you use it, the better it gets. We're able to improve consistency, speed, and again, help teams focus on what really matters most. In this case, it's getting safe, effective products to the people who need them. And while, again, this example comes from outside public health, I think you can see a lot of parallels. Think things like drafting grant applications as a first version, writing provider bulletins, or going through the process of drafting educational curriculums, giving us ideas from best practices and other industry standards. Even better, I'll say agentic AI can easily adapt to new contexts, so you can build on what you create. You don't have to start over each time. Next slide. So how do we recommend you get started? Not with the tech, start with your people. Ask questions. Where are we spending time on work that doesn't require our expertise? What tasks are slowing us down? Where do we need more bandwidth without causing burnout? We always start with this approach, co-creating with our clients. We're building solutions with the people doing the work, the people who, in our opinion, best know where the help is needed. There's a much bigger conversation, well beyond what we can cover here today, about organizational AI strategy and governance, the importance of how we make sure our AI projects align with our principles, our values, our standards, how it's implemented in ways that are trustworthy. All right, this out here. The takeaway: how do we make it easier to achieve our wildly important goals? It's not by working harder, it's by working differently, using technology, the right approach, to give our teams more time with people, with families, and with the communities that they serve. That's the work that really matters. Thank you, everyone.
Good morning, everyone. My name is Kobe Takeda. I'm the co-founder and CEO of Pear Suites. Future-proofing public health. What does that even mean, and how do we make that happen? Well, I got 26 slides and 7 minutes to share a few ideas on this topic, so let's jump right in. And by the way, who is part of the community workforce? This could be community health workers or CHWs, care navigators, doulas, street medicine providers, anyone providing community-based care around health and social challenges. Next slide. So what if we could future-proof public health? Next slide. Surprise, we can. Yes, public health is at a crossroads and our country is certainly having a moment, but just thinking about what we can control. We cannot solve for 21st century problems with 20th century tools, which is why building a technology-powered future is so critical. Next slide. But technology alone is not enough. We must continue to ensure that the future of public health is community-led, while also capitalizing on data and making public health profitable. Yes, you've heard me right. The future of public health is profitable. And I know it's a scare word for our field. I'm a public health guy myself. I know, but we are way too valuable to work for free. And no one should be jumping between jobs just because a grant ends. Next slide. Did you know that there are over 4 million frontline public health workers across the country, yet many remain underfunded and underutilized? Next slide. And what if these 4 million community workers like CHWs, which I'll focus on for this presentation, had superpowers? What could that future proof look like? Next slide. Absolutely, I'm not talking about being able to fly through the sky or shoot lasers from my eyes. Next slide. CHWs have superpowers in health education, resource linking, and ongoing navigation. If you know a CHW, you know what I'm talking about. Next slide. And with 80% of health outcomes driven by social factors, CHWs are our superhero defensive. Next slide. One of these unsung heroes, Joe Calderon, likes to say that education is great, but lived experience can't be bought or taught. Lived experience? Definitely a superpower. Next slide. So to future-proof public health, let's just imagine living in the future for a second. Next slide. Well, maybe not that far in the future. Next slide. But we do have AI for now. And just a note on the AI, I completely agree that AI won't replace humans anytime soon, especially CHWs. But humans that understand AI will certainly replace those that don't. Next slide. So let's go to everyone's favorite AI tool, ChatGPT. Not making this up, I literally typed in what would a community health worker of the future do? And let's see what came out. Next slide. First, use real-time data and predictive tools. Imagine being a CHW and always having all the information needed to be the best navigator, educator, and supporter possible. If a member's situation changes, say they lost their housing or missed an appointment, you could be pinged and could step in and support. Wouldn't that be huge? Next slide. Deliver hyper-personalized support. One day, we could be able to provide only the right information at the right time based on each member's personal history and interests, their location, their language, their cultural context, and current data from devices in their home and community. Again, data is key, and this would be huge, right? Next slide. Coordinate seamlessly across systems. Imagine CHW serving as like an API that link between many different organizations and providers across clinical and community settings and government to increase engagement and utilization. No longer will community members get dropped between organizations or complicated or stuck in this complicated system. Next slide. Fourth, get paid for outcomes. CHWs don't work for free is a mantra we can apply to the entire community health workforce. Isn't it time we properly value, recognize, and compensate our workforce? Wouldn't it be great? We can fairly pay CHWs for the success and align their work with the financial interests of our healthcare system. Next slide. Be everywhere, digitally and physically. Wouldn't it be great if we can use existing and emerging communication tools to meet members where they are and support them through both synchronous and asynchronous activities, virtually and in person? Next slide. And there you go. 5 ideas for what the CHW of the future could look like. 5 super duper cutting edge, ultra modern, avant-garde concepts we can look forward to someday in the future. Next slide. Well, I hate to break it to you, but that future is already here. Each of those 5 visionary ideas are already possible today, right now, across the country, including right here in Colorado. So maybe not so groundbreaking after all, ChatGPT. Next slide. And even the concept that community health workers can be paid for what work they're already doing is already possible now. If you're not familiar, in 2024, CMS approved reimbursement for community health worker services, and in over 30 states, including possibly here in Colorado, CHW services are also reimbursable through Medicaid, a trend that is continuing to expand across the country. Just 2 weeks ago, I heard that the state of Arkansas passed policy to make it possible for CHWs to get trained, credentialed, and paid. And other plan types, including commercial health plans, providers, and other entities, also paying for these services. So the possibilities for securing sustainable revenue is unlimited. Next slide. Of course, operationalizing these 5 concepts aren't as easy as you may think. Due to various reasons, it may be almost impossible for CHWs and the community workforce to partner across these sectors. They may still be on paper and spreadsheets. They may not know how to contract with health plans or even know what an MPI is. They may not know how to submit claims with the right CPT codes and modifiers. Next slide. So if we truly want to prepare for an equitable, sustainable workforce and future, we need to address these friction points. We need to update the workforce. We need to provide them the tools and training necessary to help community-based providers be both impactful and scalable. And because there's so much friction points with community-based providers working across the healthcare system, I started PearSuite. Next slide. So at PearSuite, we provide the tools and wraparound support for CHWs and other frontline public health workers to be technology-enabled, community-led, data-driven, and profitable, so they can reinvest that revenue back into the organization and the community. Our all-in-one platform allows users to engage with social needs screenings, track goals and care plans, engage via phone, text, and email, and automate referrals and do the claims that they need to get paid. In just 8 clicks, you can get paid for work you're already doing. And we also provide the wraparound support with contracting, claims, compliance, and care coordination. Next slide. Certainly, we're living in a moment of extraordinary possibility and enormous pressure. To future-proof public health, we need to build a new blueprint. One blueprint that can be acted on and a blueprint that we can act on now. It's not just about tech, it's about trust, community, and sustainability. And I think together, we can build a powerful, more sustainable community health workforce. Thank you so very much.
Thank you all for attending the lightning talk session. I hope you are ready to take on the rest of your day. But before that, I would love to have everyone open up for questions now.
Feel free to drop your questions in the chat or come off mute. We'd love to have you address any of our presenters today.
I have a quick question, and this is for our first presenter with Wealthy. So one, thank you for being here. Thank you for sharing this program and the data that you did. I'm curious if, one, is this program meant to replace a formal education for the youth? Two, sorry, I have multiple questions. One, is this meant to replace formal education with your certification? Is this a free program? And how are you recruiting? Or if we had a youth in mind, how can we get them involved?
So I'm going to presume you're thinking like high school level is kind of where you're asking about. Is that accurate?
Yes.
Okay. We're aligning with high school credits in two ways. So one is the delivery of health education. We actually think these virtual patients will be really valuable for that as youth learn about wellness themselves and how to care for themselves. And two is with career technical education, which is usually part of most high school requirements. I think 85% of students are involved with CTEs of some sort. And so the long answer short, so to say, is through high school. So it'll be free to students, free to high schoolers. And we have an opportunity to work in Colorado actually via our participation in Prime Health. So if you have a student in mind, please send them our way. I'll drop my connections in chat. We'd be really excited to work with them.
Wonderful. Thank you.
Thank you.
I have a question for Nick and your topic on agentic AI. I really appreciate that your team is first incorporating or thinking about talking to staff members, specifically public health staff members in this presentation. And I'm wondering if you can talk a little bit about some processes that you've worked through to help reduce the paperwork and really improve workflow for public health.
Yeah, we have had some great conversations with the workforce in the public health domain around many of the labor-intensive, document and manually intensive processes that they struggle with every day. One area in particular that comes to mind is in the area of compliance. Especially in the realm of oversight in terms of healthcare delivery. We have, in this space, we have seen situations where there are these complex multi-step processes that involve many times spreadsheets being passed from one person to the next, a lot of email-based communication, a lot of manual research, looking up in different systems or different policy documents to be able to work through each individual step in the process. And so by first starting small, like we always do, on a particular pain point in that process, figuring out how we can address that particular issue. Could be, a data entry issue. Is there a way that we can pull in information from a system without that person having to go look up in that system, copy paste or manually type information that they're finding in that system into a document? Show that we can help, get their feedback on how we're able to help. And then from there, we've got the beginning of a roadmap. We can start with, all right, what's the next most impactful use case that we can work on, and continue to build it out from there to the point where we're able to scale it across the entire process. And that's kind of the general approach that we take to working with organizations like public health organizations.
Thank you. It looks like we have a couple questions in the chat.
Can I have, I'm typing a long answer to Madison's question about how you navigate with colleagues or team members. Can I, rather than type it in there, can I answer that?
Yes, please.
And also thanks for Naomi, who found CU Data Week that my group does useful. I totally should have put that in the slide too. But I have been practicing with AI myself because I'm a skeptic. So I'm not a quick, for a biostatistician, I'm not a quick tech adopter because I want to have a little bit more established thing because we can do so much wrong with programs. But I asked my students to give me a prompt. Every student in class had as their homework, how would you use like ChatGPT for something? And I learned so much about how they learn and how smart they are as users. So it gave me more confidence of like, as we practice, we're going to learn where we can have it work well and not work well. And rather than focusing on all the places where I hate it, like my chat bots and everywhere else, I started to really see value. And that's how I taught myself to not, as an instructor, you guys all have your fears. Oh my God, they're going to put my homework questions in there. They're never going to learn anything. We're going to be educated. And that's They want to learn. And so that got me past my hurdle of it will just ruin all this stuff. And I see AI used all the time in our models, and I know the thought we're putting in our models, but that helped me see how the tools can help people learn. And so I guess I just want you to encourage your colleague to say, well, why don't you try it for recipes, or try it for something where they feel safe doing it, and rather than just these negative things, and then maybe they can integrate it in a way that they like. So I don't know if others want to add, but I really love that question, because we need skeptics, but then we also need to bridge, because it's not going to go away.
And Dr. Carlson, I'd like for you to just answer this one for everyone to hear that you've already answered in the chat. Was your content focused towards the MPH crowd or doctor and public health candidates as well?
So I answered back to that for those that didn't see it in the chat. There's a whole range. So the short courses don't require any knowledge. They're about literacy and being able to understand the terms and language we use. So we use tons of terms today that not everyone will be familiar with. And so all of those short courses, and I said you can find it at cuanschutz.edu, all the way up through courses that are only accessible to our PhDs. So they'll have to our PhDs in biostats, they'll have varying level of skills. But I think the goal of the school is to be thinking through a plan of what is the right level of accessibility for everyone, and making sure that we have content accessible to every program. And so all those courses have different prereqs, but I do think the school is moving towards a more like, should it become a core competency, and then where will it show up? But the courses I had have varying levels of, they cover all the way from you don't need any experience to you probably have done several years of math.
Thank you for that. Here's a question for the entire panel as a general AI use question for any of the AI presenters. How do you navigate with colleagues or team members who have a strong negative association?
I think Nicole just answered that one. Did she not?
Does anyone else have anything they want to add from their experiences to mine? I'm curious of others' perspectives, because I'm a little more on the skeptic side, which is probably a surprise given that I'm a data lover.
Yes, I think I also added in the chat that discussing or talking more about why are these negative thoughts or attitudes towards AI can help. But then in the field of healthcare delivery, offering CE credits and training stipends and some training time off might help healthcare providers in managing their time and burden of the patient's management, and getting more oriented towards AI.
I dropped a little note in the chat about some examples, but certainly AI may not be the primary source of information, but helping you find primary sources of information to then refer to, like doing research on studies out there and getting the evidence from sources you probably trust, could be a great solution. Of course, AI can help you summarize that. AI can help you find additional data, or look at ways to visualize that same data in different ways. So that's really great. I used to actually not use a lot of tools myself, and then all my interns and my younger staff than I, and I'm not as young as I look, but they were teaching me things, and I would always ask them, show me, let me see what you can do, and they would use that opportunity to demonstrate their skills, and I was really impressed, and now I'm a believer. So yeah, me too. Thank you.
Agree with both prior points. I would add to that as well the importance of involvement in the conversation of bringing AI to an enterprise, especially at this point of initiation. We want to have all the different points of view. We want to air all of our concerns. We want to be able to address those as a group, and then make sure that the way that we implement AI in our organization, again, ties back to our overall principles, values as an organization, that we've got the standards and oversight to be able to monitor how it's being implemented. Transparency, I really completely agree on that in terms of being able to understand what's happening and be able to explain what's happening when we get asked questions about the outputs of AI. So yeah, for us, it's a larger conversation, including different points of view from across the organization to allow people to provide their input and feel comfortable with it.
I forget, there was also the first two questions, and one of them was about equity and training or using data with equity when the person who introduced us all. Am I remembering that right? I guess I just have a comment on that, especially in the current administration. I guess I challenge everybody who works with data to think about what is the population in that data set if they're working with data. And I do think with big data is giving us a false sense of security of it must be comprehensive. And I'll give the example of until recently, the All of Us data set had no Native Americans in that data set. And so it can't be generalizable to all the populations we work with. And I'm working with people who do this Trinetics Health System, which has hundreds of hospitals contributing data in it. So it's got so many, it must be representative, and it's not, right? They're insured people. They don't have safety net hospitals. So we've been really working with people to think about, okay, if you're going to use this data set to derive conclusions and use it for data, what was the population, which is basic epidemiology as a public health professional, but I think we get a false sense of security by the size of all of our data. And so making sure these models are trained on the populations we want to use them and are retrained all the time will be critical. And I hope that is, if I remember the question right, we can be great advocates of let's see how this model works in our population and not just assume that because it was AI and they done all this other stuff, it's going to work in our setting because it may not have been trained on the population that we want to apply it to.
Thank you so much for that addition. We have a question about the youth council programs. How is the youth council on mental health currently recruiting youth? And can you give examples on what work the youth are doing right now?
Yeah, I can take this one. The youth council. So a lot of our recruitment is like based on community organization and those partnerships that we've already established. So it's a lot of collaboration with schools, like other youth serving nonprofits. So kind of like going around the community. We also do a lot of peer-to-peer outreach when it comes to that. So like making sure that our current council members can like go to their other friends and recruit in that way. And then what was the other question? And then the work that we're currently doing, so our 3 teams, so the community action team right now, they're putting like a block party for the community. So that's a really cool event. We also have the patient experience team, and they are creating a survey where like a survey for youth about their experiences when it comes to receiving care at Children's Hospital. And the program innovation team are doing live research and giving feedback on different trainings.
We are also currently recruiting for our YCMH. I put our link in there. Our applications close April 30th. I also put the link there to our applications, and there you'll also find a little bit more information on our different teams and the work that we're doing.
All right, it looks like we've got one question directed towards Nick and Colby that Colby's already started to answer in the chat. For those who want to leverage AI tools and improve public health processes, how do you balance the benefits of these tools with environmental impact of AI?
Yeah, I can share a few thoughts there. Strategically, I think it goes back again to the transparency aspect of it, making sure that we're able to understand the environmental footprint as part of our broader approach to governance. Also, being intentional, kind of more tactically here, being intentional about how we're using AI. Think about where we can use it meaningfully in ways that will be more purposeful, like cutting down on paperwork, rework, the administrative overhead, like we've talked about. And also sort of what we would call life cycle thinking, thinking about projects that require minimal retraining of models, leveraging what we already have developed, building off of what we've already developed in a more reusable kind of way.
Yes, Dr. Moyo.
This isn't on the environmental question, but I wanted to just address Kylie Yoakum's challenge or thought around how do we ingrain the health, justice, and equity principles. I think this also touches on the question about whether people feel comfortable with AI. I think it's really important that people who center health, justice, and equity not only use these tools, but build these tools. And I'd say the third thing is apply them, because we will be the ones who will make sure that these new technologies get used for health, justice, and equity. It won't be people who don't think about this or don't care about it. It will have to be us. And so for those of you who might be on the sideline about AI, my challenge to you would be get off the sideline, get on the playing field, play around with it, because it is going to be impactful in public health, in healthcare, in education, all of these key underpinnings of public health and wellness and in sort of human longevity, whatever you want to call it. But I think it's really, really critical. And for example, I'm a father. I have a 4.5-year-old. Nobody taught me how to teach my kid how to read, right? And so reading and literacy is one of the most important things. And so I was utilizing AI just the other day to be like, how do I teach my kid how to read in a fun way, right? I can read to them, but I actually don't know how to teach them. And that to me is utilizing an AI tool this is just coming to me now, but it's using an AI tool in a equity-minded way, right? Youth are the most vulnerable people amongst us, and if we don't use these tools in that way, then they won't get the benefit from it. So just on my soapbox this morning, I guess.
Thank you. And kind of a follow-up on that is, how do you better participate in that building process? Is it a matter of refusing prompts like Madison in the chat is suggesting? How do you better suggest people participate in this process?
Getting involved in communities really helps, especially communities that are being led around AI, and then just being that voice in the room to center it around health, justice, equity, public health, whatever you might mention. If you are in the entrepreneurial world, I know we were part of the inaugural cohort with Google actually for their AI for American infrastructure. We focused on public health. I know they're launching their second cohort now, so that if you are a entrepreneur out there, that's something to think about in terms of getting involved. And then I think the private-public partnership is going to be key, because if you're a public health agency, often this isn't the world that you're in, isn't what you live and breathe every day. But finding companies like Wealthy, like PearSuite, like some of the companies that you've heard of on this call, or organizations, to find those partnerships where we can work together with academia and with entrepreneurship or private companies, I think can be really powerful as well.
Would anyone else like to add to that?
I'd just add that there's a lot of questions looming right now around how we can partner together, and a lot of work groups and groups kind of working on this in councils and committees and different associations and nonprofits and for-profits and think tanks. And so definitely get involved. I mean, one of my colleagues is on the AI and the safety net work group across the West Coast, and another team member is on the health equity committee for the CTA Foundation for their kind of standards around how to build consumer technology products that incorporates health equity, and also, of course, they're doing a lot of things on AI. So read up on what's happening out there, join the conversation, contribute, share your thoughts, share your concerns. I think all that's really critical.
All right, I think we have time for 1 or 2 more questions if anyone has them. Otherwise, we will wrap up for the day or for the session. Okay, seeing none, thank you all for attending this lightning talk and being so participatory in the question and answer period. A few short announcements before you head out. Slides and any additional handouts the speakers have provided will be available on Sched, and in the chat, they have provided their contact information as well. Here's a QR code to our conference evaluation. Please, 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 if you have any time, participate in this. We do take in all of this data to improve your experience every single year. You'll also receive a conference evaluation form via email after the conference is over. So please fill this out. Even if you only attended a portion of the conference, it really is helpful in planning every single year. The recordings will be available, and we'll follow up with an email when those are ready. And enough from me. Let's go ahead and get into our sessions for the rest of the day, starting with our concurrent session D, which will begin at 10:30. So thank you all for your presence here. I cannot wait to hear your thoughts. And once again, welcome to day 2 of Culture of Data 2025.